Hi and welcome to the channel Love Obstetrics and Gynecology. This video is on shoulder dystocia. Shoulder dystocia is an obstetrical emergency that affects nearly 0.6 to 1.4% of all pregnancies. It can be both unpredictable and unpreventable. To define shoulder dystocia, it is basically the failure of shoulders to traverse the pelvis spontaneously after the delivery of the fetal head. And any delay in the delivery of the fetus can lead to fetal hypoxia, or if inappropriate maneuvers are performed, they may lead to fetal injury. In some cases, we might be able to anticipate the shoulder dystocia, but in others, without any risk factor, shoulder dystocia may occur. So, we can perform various external or internal maneuvers to deliver the baby. And usually the external maneuvers are performed first before the internal maneuvers, as they are considered more easy and safer. Now talking about some risk factors, though shoulder dystocia can occur in a pregnancy where no risk factor was associated with the shoulder dystocia, alright, but yes, there are certain risk factors in which we can predict the patient might land up in a shoulder dystocia, and we keep our preparedness even more. So those conditions you can see on the screen, that is gestational diabetes mellitus, post-dated pregnancy, advanced maternal age, multiparity. All these conditions are somehow related to a fetal macrosomia. And the other way if we look at it is there is a big fetus, or there is some issue with the pelvis. So the issue with the pelvis, you can say the woman is short stature, or she has a contracted pelvis, or a flat pelvis, which we call it as platypod pelvis. So somewhere there is disproportion between the baby size and the pelvis, which is basically responsible for the shoulder dystocia. Also some fetal risk factors such as fetal macrosomia, as we already considered according to the maternal aspect also, and the sex of the fetus if it is a male fetus, any congenital malformation of the fetus such as anencephaly. And there are various labor related risk factors such as if we are plotting a graph and we are seeing that the first stage or the second stage of labor has been protracted, there might be a possibility of shoulder dystocia. Also, if we were using oxytocin or other inducing agents, they are also responsible. They might be responsible for shoulder dystocia later on. And if we are going for assisted vaginal delivery, such as a vacuum or a forceps delivery, you apply that to the head of the fetus, you can anticipate the shoulder dystocia along with it. There are two types of shoulder dystocia, but most commonly we have the unilateral shoulder dystocia, and that is also of the anterior shoulder when that is stuck above the pelvic brim. Or we can have both of those bilateral shoulder dystocia, that is the posterior shoulder is also above the sacral promontory. The clinical diagnosis is when the obstetrician faces a difficulty in delivery of the fetal head delivers, there is difficulty in delivery of the face and the chin. And as it delivers, the head recoils back onto the perineum, and there is failure of restitution of the head as well as descent of the shoulders. So if there has been a delivery and delivery of the head has occurred and the head recoils back onto the perineum and you are unable to make out for the restitution, and there has been a 60-second elapse from the delivery of the head to the descent of the shoulders, we classify it as shoulder dystocia. Now let's talk about the management. See, in the management you have 5 minutes to deliver the body of the baby. And you need to be quick, but you have to maintain a calm inside your mind so that you can perform logically. So the first thing is, as soon as you have recognized the condition, you call for help. You require extra people to help you. Those extra people can be staff nurses, or you have to call a senior obstetrician or a senior consultant so that he or she can help you. You require a neonatologist. So after calling those extra people, now you have to perform the maneuvers. And for each maneuver, you can give to that maneuver 30 seconds, and then you have to switch on to the next one. And in any of those maneuvers, do not provide any undue traction or rotation, as they may cause fetal injury. So perform the maneuvers in a correct manner. So firstly, the external maneuvers, in which first we'll talk about the McRoberts maneuver. See, in this maneuver, the basic technique is we slightly abduct the legs and flex those legs onto the maternal abdomen. And in doing so, we are also lifting the pelvis a bit, or the maternal buttocks a bit. The basic mechanism behind it is it leads to a change in the pelvic inclination angle. The pelvic inclination angle decreases as you are moving the pelvis scaphoid head. The lumbosacral curve that gets flattened and the pelvic inclination angle decreases, which basically means that your shoulders are facilitated to enter the pelvic cavity, and there is no effect on the pelvic outlet. Okay, and how do we perform this maneuver? You require two separate assistants, one on each leg, and they grasp the thigh from the posterior aspect and they flex it onto towards, or flex the thighs towards the maternal head, and while doing so they are lifting the maternal buttock. And along with this support, the person who is delivering the baby provides a little fetal axial traction on the fetal head. The second maneuver is suprapubic pressure. It can be given alone or along with the McRoberts maneuver. The technique behind the suprapubic pressure is basically that you provide the suprapubic pressure on the maternal abdomen from the side from which you suspect there is the fetal back, and you provide that pressure that will lead to the adduction of the fetal shoulders and a decrease in biacromial diameter of the fetus, and along with it, it provides some rotation. So the shoulders that were in the AP diameter of the pelvic inlet will turn towards the oblique diameter of the pelvic inlet, which is more capacious. So now coming on to how we perform this maneuver. So first is we clasp our hands just like that, and with the heel of our hand we provide the suprapubic pressure from the side on which we have the fetal back, and then you provide that pressure. Firstly, this pressure should be given steady, in a steady manner. If that fails, you can go for the rocking motion like a CPR resuscitation based being done. Now talking about some disadvantage of the external maneuvers. So you require 2 to 3 assistants to perform these maneuvers, like 2 on the leg and a separate third person on the suprapubic pressure. Another disadvantage is that if the patient is obese, it will be difficult to pick up her leg and flex it onto the abdomen. Also, the maternal obesity on the abdomen, as you are providing your suprapubic pressure, that pressure won't be that effective as it would have been in a lean patient. So these are the disadvantages of a external maneuver. Now coming on to the internal maneuvers, first we have is Rubin 2 maneuver. In that maneuver, basically you insert your hand vaginally and you provide a traction from the posterior aspect of the anterior shoulder. So you're basically giving it the same technique as we used in the external suprapubic, but we applied the force externally. Here we are applying the force internally. So you go inside the vagina, find the back of the fetus, go behind the anterior shoulder, and then try to dislodge it or rotate it towards the more oblique diameter. And while doing so, you are basically rotating it and adducting it, which will lead to a decreased biacromial diameter, and the rotation as such helps in moving the shoulders to a wider diameter and helps in delivery of the fetal shoulders. The next maneuver is the wood screw maneuver. In this, we require two persons, one manipulating the fetus from inside the vagina and other one from the external aspect. So internally, first talking about that, internally you go and try to find the posterior shoulder, and then as you find the posterior shoulder, you provide the traction from the interior aspect of the posterior shoulder. So you try to rotate that, and externally one person will provide the traction on the back of the fetus, that will be from the posterior aspect of the anterior shoulder, so that you can rotate the fetus. Again, that will lead to two things. First is reduction of the fetal shoulder, second thing is rotation to a more oblique diameter, which is more capacious. The thing is that in these rotational maneuvers, if you achieve you can achieve approximately 180 degree of the rotation, but even if you achieve 30 degree of rotation, that might be able to disimpact your anterior shoulder and it delivers your baby. The second thing we are considering in these rotational maneuvers is that your fetus posterior shoulder is considered to be at a lower aspect than the anterior shoulder. So as the fetus rotates by 180 degree, which means your posterior shoulder, when it becomes anterior, it will be below the pubic symphysis and your shoulder dystocia will be revealed. Another thing is the internal maneuvers can be performed by a single person, such as in Rubin 2, which is definitely can be performed by a single person, but those internal rotation maneuvers, they can lead to fetal injuries more. So they have a certain kind of advantage, but they also come with a certain kind of disadvantage. Hence, it is always recommended that you perform the external maneuvers before the internal maneuvers. Now coming on to another very interesting internal maneuver, which is posterior arm extraction. So the posterior arm extraction or delivery of the posterior arm is considered as an internal maneuver that has a very high success rate in comparison to the other rotational maneuvers and the external maneuvers too, and it is also considered as very safe if performed adequately. So basically we go in the vagina and extract the posterior arm. The mechanism behind it is that you decrease the biacromial diameter to a acromio-axillary diameter. That leads to a decrease in 2 cm of the diameter, approximately that, which definitely helps in relieving the shoulder dystocia. And along with that, as you bring the forearm out, you rotate the baby, so it is combined with the delivery of the arm is combined with the rotational maneuver. Now let's see how we perform it. So basically you insert your hand in the vagina and you trace for the fetal chest, and as you have traced that, along with it go find the posterior arm and the forearm. So forearm is the point where we are going to grasp the baby's arm, forearm, and then we try to bring it outward and upward. And as we do it, we give some kind of rotation that actually gives itself a kind of rotation, and your fetus rotates, and that relieves the shoulder dystocia. And in case the fetal arm is extended, you can compress the cubital fossa. That will lead to a flexion on the forearm, and then you grasp the forearm and bring it outward and upward. That will, along with rotation, deliver your fetus. Next maneuver is all fours maneuver or the Gaskins maneuver. Here the patient is turned upside down, and she rests on the hands and knees. This basically, the mechanism behind this is the gravity helps in disimpacting the shoulders. The sacral mobility is increased. The sacral curvature or the pelvic inclination angle, that is decreased, and your access to the posterior shoulder, that increases. All of these are helpful in helping in just the pelvic inlet. None of these change the pelvic outlet. And there is one more position known as the knee chest position. So this is now the exact reverse of McRoberts plus suprapubic pressure. The disadvantage of this maneuver is that the patient might not prefer this birthing position, or if you are you have been doing it with the instrumental delivery, or the patient has been provided a regional anesthesia, then this position is not definitely possible for those patients. Also, we have the posterior axillary traction or posterior axillary sling traction maneuver. In both these maneuvers, basically we are providing the traction to the posterior shoulders axilla. So in axillary traction, we give it manually by our hands. The basic mechanism is that you or the technique is that you give make a sling around the posterior shoulder and around the axilla. So you can do it by one hand. If you have big hands on the big fingers, you can provide that pincer grasp like this, and you hold that shoulder and then try to take it out. And in case you do not have you cannot grasp it by one hand, you can use two hands. The middle of finger of both the hands, they provide a sling, or they provide a pincer grasp around the shoulder, and then you provide the traction as well as slight rotation. And same can be done by the, you wrap a ribbon gauze around the axilla, and then you provide an upward and lateral traction that will lead to the descent of the posterior shoulder as well as the rotation. Lastly, coming on to the invasive procedures. See, the invasive procedures are performed under some anesthesia, so you require an anesthetist right now. And also these procedures are performed when we consider that the fetus has now suffered so much of hypoxia that it cannot be revived now. So these are performed when fetus is considered as dead. So the first maneuver that we have is the most safest from all these destructive maneuvers is Zavanelli maneuver. In the Zavanelli maneuver, you provide adequate uterine relaxation, and then you replace the fetal head back in the uterus, and you go for a cesarean delivery. Next we can have is clidiotomy. Basically that refers to the intentional fracture of the clavicle. Next we have a symphysiotomy. That basically refers to the separation of the pubic symphysis so that the epidiameter of the pelvis can be increased in that aspect, so that it relieves the shoulder dystocia. All these destructive procedures are performed very rarely. So some do's and don'ts. Do's: first, call for help, clear the infant's mouth and nose. Don'ts: don't get panic, don't provide any undue traction or any undue rotation. Stay calm so that you can deliver the fetus in a quick manner without any fetal injury. Immediately after the delivery of the baby, your neonatologist should be ready for the resuscitation of the baby, and you should look out for any maternal injuries and also have a watch on PPH, as this patient has now been handled and she has high possibility of postpartum hemorrhage. After managing the patient of shoulder dystocia, an important thing is documentation. In that documentation, it should include the particulars of the patient, the details of the staff that were present before the shoulder dystocia, and also the add-on staff that came after the call for help. Then also write about the maneuvers that you performed, in which order, at what time they were started, at what time the head delivered, and how much time did it actually take to deliver the body of the baby. All the maternal details, all the baby details, they all need to be documented very properly. And also you need to mention regarding the episiotomy, if that was given, or any tears that happened, and also any maternal injury that has occurred or the fetal injury that occurred. Also whether the fetus or the baby now born that has been admitted to the NICU or not. So both maternal and fetal injuries can occur. Firstly, talking about the maternal injuries, there can be definitely an extension of the episiotomy that we have given, or other related tears such as a midline tear, a vaginal tear, or a cervical tear. And that may lead to a traumatic PPH, or that may be associated with other form of PPH such as atonic PPH. On the long run, she can have fistula formations or maternal symphysial pain if any symphysiotomy was performed, or as such pelvic pains can occur. And while performing the McRoberts maneuver, if you abducted the legs too far, that may lead to the damage to the lateral cutaneous nerve, so that may be injured. So all these maternal injuries can occur, but along with that we have to also look for the fetus, and there are some fetal injuries that can happen definitely, such as the Erb's palsy, the fetal humeral fracture, or the clavicular fracture, the brachial plexus injuries. Any kind of injuries can happen to the baby. The obstetrician's skill and the team coordination are utmost important in saving the fetal asphyxia and having a happy and healthy child and mother. So in all these maneuvers, basically it is your skill that helps the woman. You do not require much of a specialized training, or you do not require much of anesthesia. It is your repeated performed skills or repeatedly performed drills that help you improve your skills and help in managing the shoulder dystocia. So coming on to the HELPERR mnemonic. H, call for help. E, give episiotomy. L, elevate the leg, that is perform the McRoberts maneuver. P, provide the suprapubic pressure. E, enter maneuver, which is the rotational maneuvers, internal maneuvers. R, remove the posterior arm. Another R, roll the patient, that is the Gaskins maneuver. So this was all regarding shoulder dystocia. If you like my video, please do like, subscribe and share the channel Love Obstetrics and Gynecology. Thanks for watching.